Hi, good evening, everyone. You're very welcome to this evening's webinar. We will get started in a moment. We'll let our numbers pick up. I have pressed the record button, just so you're aware, and we'll get started in a moment. Thank you. Okay, I think we might get started. So we will pull up our intro slides and get underway. So you're all very welcome to this evening's webinar and a topic we're very excited to host here in the Irish Institute of Pharmacy on cervical cancer screening and prevention. Just by means of domestics, as I say, I've pressed the record button already, and the recording of the webinar this evening will be posted to our website in the coming days. We ask that you keep your microphones muted if possible, and you're very welcome to have your cameras on or off, whichever you wish. We'll share a survey at the end of the presentation this evening, and we very much welcome your feedback on this webinar and any future webinars you would like to see from us in the Institute. So we might just move on 2 slides if possible, please. Thank you. Moved on from me. Just sorry, now bear with us.
Do you want me to pop them up, Grace? Are they getting stuck on you?
Thanks, Audrey. Yep, that's perfect. And so to introduce our speakers then this evening. Thanks, Audrey. So our first speaker is Dr. Sarah Fitzgibbon. She's a primary care clinical advisor with CervicalCheck HSE. And then our second speaker, briefly towards the end of the presentation, will be AnneMarie DeFrein, who's Chief 1 Pharmacist with the National Cancer Control Programme. So we're really happy to have 2 excellent speakers to enlighten us on the subject this evening. So I will hand over to Dr. Fitzgibbon now, who will share her slides. So again, bear with us as we get underway here. And as always, we very much welcome questions, but if you could keep them to the end, if at all possible, that would be fantastic. And we'll have a Q&A at the end. And we will also be sharing some resources into the chat box as Dr. Fitzgibbon moves through her slides. So if you are interested in collating those as resources, but we'll also share those resources as well as part of the recording, as footnotes to the recording as well. So handing over then to Dr. Fitzgibbon, thank you very much for joining us this evening.
Thanks a million, Mary Claire, and I hope everybody can hear me and that they can see my slides. You'll holler at me if you can't, hopefully. So as I've been introduced, thank you very much for that. I'm Sarah Fitzgibbon. I'm a GP in Cork, and for the last couple of years I've been the primary care clinical advisor with CervicalCheck. And on the call as well this evening we have Lynn Swinburne, who's a senior health promotion officer with the National Screening Service, and she's going to be providing lots of lovely information, those links into the chat as Mary Claire was mentioning. And Lynn is also a fountain of all knowledge about screening. So if there are questions that come up later that I'm not able to ask, I'm going to be passing them over to Lynn. So what we're going to cover this evening, hopefully, is that I'm just going to tell you a little bit about CervicalCheck, the program itself, and then talking a little bit more about screening, the considerations around screening as a health intervention, and then more specifically about primary HPV screening, which is the screening test that we do for cervical cancer in Ireland now. I'm going to talk briefly about HPV vaccination, which would be another arm of cervical cancer prevention. And then we're going to talk about the really exciting prospect of cervical cancer elimination. So the possibility of making cervical cancer an extremely rare disease in Ireland and how we're hopefully going to be able to do that. And then I suppose most importantly, from my perspective, I'm really interested to hear about the role of pharmacists in cervical cancer prevention. So we have a few ideas ourselves about how pharmacists can and do help us in the work that we do around screening, but absolutely I'd love to hear hear from yourselves more so about that, and let us know how we can help each other to increase screening rates in Ireland and to make sure that the screening experience is as good as it can be for everybody. So I suppose just an overview of what the cervical screening programme in Ireland involves. And CervicalCheck itself is an organised and population-based quality assured national screening programme. And so what that means is that it's a programme intended to screen as many women as possible in the target population, to identify those who are at increased risk of having precancerous cervical cell changes. So the programme is not looking for cervical cancer, it is looking for those who are at increased risk of developing cervical cancer. And when we find people with increased risk, then we manage them in a way that means that that risk is monitored. And if they require further investigation, diagnosis or treatment, that is also provided. So if we look down here at our little graph, we can see that we have our population of eligible people. So that's anybody with a cervix is eligible to have their cervix screened. And they are invited by the programme through our screening register. So we have a register of all the eligible people in Ireland, and that's provided to us through the Department of Social Protection. So that's where our information comes from about the people who are within the age range of 25 to 65 who are eligible for screening. And we send out, the programme sends out invitation letters once a person hits the age of 25. And we also send out letters to remind people when their screening test is due. If a person doesn't have a letter, that doesn't mean that they can't come for screening. If they are between the age of 25 and 65 and they have a cervix, then they can come for screening whether or not they can find the letter in the bottom of their handbag or whether they can remember whether they were supposed to come or not. It's also possible to check online with our check the register function in CervicalCheck.ie. And so anybody can pop in their PPS number and their date of birth, I think, and name, and then it will tell you when your next screening test is due, which can be really useful for people like me who can't necessarily keep track of these things. So once you had your letter, you come to a sample taker, as we call them. So generally that will be a practice nurse or a GP in a primary care setting who will take your screening test for you. We're all very used to calling it a smear test. Because we've moved to HPV screening, it's technically a cervical screening test as opposed to a smear test, but still plenty of us will still refer to it as a smear test. The screening test is sent off to a laboratory and analysed, and it's checked for the HPV virus. And I'm going to be talking a little bit more about HPV in a second. But basically with that test, it's sort of a yes or no answer. You either test that you have HPV or you don't have HPV. If the test says that, yes, currently there's HPV in your sample, then that sample is checked under a microscope or in a test that we call cytology, which is what was the traditional smear test. So looked at by a cytoscreener or a medical scientist under a microscope, and the cells are checked. For some people, they would have HPV positive as a result, but when their cells are checked, the results of the cytology test is negative. So we know there's HPV there, but the cells look fine. For those people, they have repeated HPV testing 1 year later. And again, we'll talk about the rationale behind that. For anybody who has abnormal cytology results, so that when the cells are looked at under the microscope, they don't look perfect, then that person is referred on for diagnosis and treatment through our colposcopy clinics. And there are 15 of those around the country. If for some reason the test is unsatisfactory, you need to have it repeated again, but you need to wait at least 3 months between screening tests. So if it has to be repeated, you still have to wait 3 months, and that's in order for the epithelial cells on the cervix to grow back sufficiently to allow a good test to be done. And those people who are sent off to colposcopy, the vast majority of them will actually be found to have no abnormal cells when they're examined through our diagnostic arm, through colposcopy, and they go back in again to our normal invitation recall system. So it's a little circle that goes around between the ages of 25 and 65, and everybody should find their way along that pathway. And hopefully, as I say, that pathway would be easy for people to follow and participate in. So this is just an overview of where CervicalCheck lies within, I suppose, the overall system of the HSE and everything else. So the National Screening Service runs 4 screening programs, 3 for cancer, breast, bowel and cervical, and then 1 for diabetic retinopathy. So I won't go through all of this here, but you can see that we have various different advisory groups that are monitoring and providing leadership and direction to the program, and the more specific advisory groups, the laboratory, colposcopy, primary care, and more recently an education advisory group. So these are a number of external and internal experts in their field who are advising the program on best next steps, and we're constantly and continually trying to improve our service. And this timeline here is just showing us that CervicalCheck, cervical screening as a national screening program, only started in Ireland in 2008, which really isn't that long ago. I think that might be 15 years ago. My maths is so bad that it's a struggle for me, but you can see it's not that long ago. Before that, there was a pilot program, but it became nationwide in 2008. And then in 2009, at the very sad death of Jade Goody, which was, I suppose, a very public experience, in the sense that it really brought cervical cancer and the I suppose the harms of cervical cancer into a lot of people's consciousness. And we noticed a massive increase in screening levels in Ireland and in the UK around that time. In 2010, we had our first launch of HPV vaccination. And so the science and the work that had been done around HPV since the mid-1970s came to fruition with the discovery and development of a HPV vaccine, which really was a massive breakthrough for healthcare in so many ways. And then in 2011, there was a catch-up program again, so really trying to make sure that the young girls in the eligible category had every chance to get HPV vaccination. HPV testing became part of the screening pathway as well, but this was initially in colposcopy. So when there were some uncertainties about somebody's risk level, so again, looking at cells, which is what they do in colposcopy, and looking at cervixes themselves, sometimes it can be a little bit hard to see if there are abnormalities, whether or not they are likely to progress to cancer or whether they're more likely to regress and go back to normal, which in fact happens a significant amount of the time. It's more likely, if you have abnormal cells in your cervix, that they're going to actually go back to normal by themselves than that they are going to progress to cancer. But finding out whether you have HPV or not, between those times of 2012 and 2015, it really became more obvious how useful HPV was and HPV detection was going to be. So in 2016, the HIQA, the Health Information Quality Authority, started a health technology assessment. So looking into the idea of using HPV as a primary screen. And so they looked at international data, they looked at all of the available information to see, was this going to be an appropriate thing to bring in Ireland? And in 2017, they came to the conclusion that yes, indeed, it was a good idea to bring primary HPV screening into Ireland. So it had been already introduced in places like Australia, which is really quite advanced when it comes to HPV research and evidence. And it was apparent from lots of places around the world that HPV was going to be the next best step. In 2018 in Ireland, we had the unfortunate events that led to the Scally report. And obviously there was a huge upheaval within screening services, within the public consciousness around screening, and particularly cervical screening. And of course, there were consequences around that in terms of service delivery, people's expectations, all of those things. So naturally, it had a significant impact on the cervical screening program. In 2019, we moved to the stage where every child in first year in school was offered the HPV vaccination. So both boys and girls are now offered the HPV vaccination. And that's really moving towards that situation where we're going to have much less HPV virus going around in the community. And then in 2020, at the end of March 2020, was the start of the HPV screening program. So it was all getting prepared and delighted, and it was going to be launched at the end of March 2020. Obviously, there was another virus going around in March 2020, which sort of put a scupper on some of those plans, and screening was halted between March of 2020 and July 2020. But in July, GPs, practice nurses were all back on track, screening, doing cervical screening in their surgeries, but this time with HPV as the primary test that we were doing. So these, just to have a look at all of the people who are involved in providing a cervical screening program in Ireland. So there are 40 cervical check staff based in the offices in Limerick. We have at least 4,000 sample takers. So these would be in primary care, general practices, practice nurses. There are also some sample takers in secondary care as well, in gynae clinics, in STI clinics, etc. There are 2 main HPV and cytology labs that are used by CervicalCheck, one based in the Coombe Hospital in Dublin, and the other one based in Quest Laboratories in the States. And then we also have histology labs who would complete the histology testing of the samples taken in colposcopy. And then dotted around the country on our little map there on the left, you can see our 15 colposcopy units. So these are providing services that are geographically convenient, hopefully, to the vast majority of our population. So if we just think about screening itself a little bit for a minute, so it's really important to remember that screening programs are for healthy people. They work best and possibly only really when they are based on a population level. The screening aims to improve the outcomes for the condition for the population as a whole. The condition that you're screening for, in our case, it's cervical cancer, and the way of screening, and in our case, that is through our cervical screening test. These need to meet certain defined criteria, which are these Wilson and Younger criteria, which go through, I suppose, all of the different aspects of what makes a screening program effective. And it's really important that a condition would meet those criteria before we decide that it should be screened for. And this would include the fact that the test is acceptable to people, that the test is causing more good than harm, that if you're found to have the risk factor that's being screened for, or the condition that's being screened for, that there are adequate services to manage that, because it would be exceptionally unfair to go and find a load of people with risk factors and then say, oh, actually, we can't do anything about it. So there are these criteria that need to be adhered to and met with a screening program. And every single screening program is a balance of benefits, harms, and affordability. So each screening program has benefits and has harms and has limitations. And also you need to bear it in mind from the point of view of from an overall health economics perspective. So it needs to be affordable throughout the course of the screening program. By affordable, I mean for the state, obviously screening in Ireland is provided free. And so if you think about screening tests as like a sieve, so screening acts as a massive sieve for a huge population of people, and every single person goes into that sieve. The aim of the sieve is to find the people in the population who are at increased risk of this particular condition. The sieve isn't perfect. So some people will end up passing through the sieve that in fact are at high risk, but the sieve deems them to not be. So despite being high risk, they're actually told, no, everything is fine. You don't need any further tests. What the sieve is aiming to do is to find those people that do require further tests, send them on for those tests. And then after those tests, and that would be the diagnostic end of things, remembering a screening test is not a diagnostic test. The screening test discovers should you have, or recommends that maybe you need diagnostic tests, and you go off and you have those. And then depending on those, you're you're provided with either advice and support or specific treatment, or it might be that no further action is needed. Sorry, now my clicker isn't clicking. So we were talking about, I've been talking about HPV all this time, and I suppose just to focus back on what we're talking about. So HPV is the human papilloma virus. There are over 100 different subtypes of HPV. It is extremely common. Pretty much anybody who's ever had sex with anybody will certainly have been exposed to HPV and is likely to have picked it up. And it causes no symptoms, so a person is not going to know whether they have HPV or not. Some of the types of HPV cause genital warts, and those types of HPV that cause genital warts are not the ones that cause cancer. So one could say that one of the only symptoms of a potential HPV infection would be genital warts, but that is not the higher risk subtypes of HPV, which are the ones that we're particularly keen on finding, because they're the ones that can cause cancer. The HPV virus for the vast majority of people, remembering loads of people get it, but most people, the vast majority of people, get rid of it by themselves with their own immune system, and generally within 18 to 24 months. So lots of us get it, most of us get rid of it. But for some people, the HPV persists. So it doesn't get cleared by our immune system, and that can be for lots of reasons. We know that people who smoke are less likely to clear HPV. It can happen for some people with immunocompromise, but it's not very predictable in the sense that anybody really could find that they end up with a persistent HPV virus. And it's the persistence that is the main risk factor for cervical cancer. We know that for squamous cell cancer, which is the most common type of cervical cancer, that HPV is responsible for over 99% of cases, almost all. It's very rare. Nobody yet has found a squamous cell cancer that isn't caused by HPV, put it that way. But there are other types of cervical cancer, and it's because of that reason that detecting HPV and preventing HPV cannot completely get rid of cervical cancers, because other types of cervical cancer are caused by other things, are not related to HPV. Those other cancers, those other types of cervical cancer are not screenable for. They're not something that we can screen for, whether we use HPV testing or any other type of testing. They're just not screenable types of cancer. And the persistent HPV takes up to 20 years to develop into cervical cancer. So if you have HPV and it hasn't gone away, it's actually going to take 15 to 20 years for that to cause enough changes in your cells of your cervix to cause invasive cervical cancer. So it tends to be slow growing for HPV related diseases. This just, I suppose, goes through that in a pictorial sort of way. So we're saying that you get exposed to it. Your lifetime risk is around 80%, as far as we can tell. For most people, it's transient. It will go away within 18 months. For less than 20%, it will persist. And then what can happen for some people is that there is this malignant transformation where the virus goes into the host DNA, and there's complicated cancery things happen, and it causes precancerous cells. Again, just remembering precancerous cells, not necessarily invasive cancer. So it is a long process, and also one that we have clearly mapped out. We know how this happens. So again, I suppose just to bring that all back together again, what we're saying is that the screening test for cervical screening in Ireland is HPV primary screening. We're looking predominantly for HPV. If you have HPV in your test, you go on for further testing. If you're HPV negative, then your risk is really, really low, and you have your next screening test when it's due. Our age range is between 25 and 65. For those who are between 25 and 29, you're screened every 3 years. And that's because so many people will have HPV in their younger years. You're much more likely to get it when you first become sexually active. And after that, then you're less likely to get HPV. It's still really important, obviously, that everybody gets screened up until the maximum screening age, which is 65. Anybody with a cervix, if you don't have a cervix, you don't need cervical screening. And if your HPV proves to be persistent, so you've had a positive HPV test and you have another positive HPV test, or if you have any abnormal cells when your sample is looked at, then you're referred on to diagnostic services in colposcopy, where they will decide if you need treatment. And just a reminder again, I suppose, about what happens with your result. So your HPV positive result is looked at under a microscope in the cytology lab. If there are no signs of any changes in the cells, then you just have your HPV test repeated 12 months later. If there are any sign of changes in the cells, the cervical cells, then you're referred on to colposcopy. If your HPV test is negative, that is a really reassuring sign. You're at very low risk, and you have your screening test again when it's due in either 3 or 5 years' time. I suppose some people might ask a question about comparing our new test to our old test. So our HPV test, which we've had since 2020, what we know is that for every 1,000 women screened with the old test, the cytology test, for every 1,000 women screened, 20 of them will have precancerous changes. So that's the prevalence of precancerous changes in 1,000 women. Of those 20, 15 will be found with our traditional cervical test, our smear test, our cytology test. And 5 would not be found. With our new test, the HPV test, 18 of those 20 women will be found, but 2 will not be found. 2, even though they have precancerous changes, will not be found with our HPV test. There is no cervical screening test that prevents 100% of cancers. This is a little bit more detail here of those 1,000 women that we were just talking about. And I suppose just to give a clear idea of what happens to women and how likely we are to find a cancer. So of the 1,000 women that are screened, 110 of them will be found to be potentially at higher risk and will be referred to colposcopy. Of that 110, only 15 will actually be found to have anything that's wrong with their cells. So they will have abnormalities that are precancerous. But 95 of the people who've gone to colposcopy will be told, actually, everything is fine. We were just double checking and actually everything is fine. Of the 885 people who weren't referred to colposcopy, so they were just told your test is normal, you don't need to go anywhere, everything is fine. 5 of those will actually have precancerous changes. So these will be the 5 people that have potentially been missed. And this is what we're talking about, our cytology again now. So this is our traditional test before our HPV test. And of those 5 here that had changes but that weren't found in the test, and of these here, the 15 who had changes and were found, only 0.1 of them will turn out to have invasive cancer. So we have our pre-cancer stage that these people might be at, and out of the 20 of those, only 0.01 of them will turn out to actually have cancer. And that's our rate, our population rate of 11 per 100,000. So I suppose it's just a reminder for everybody who's having a screening test that actually the risk of you being a person that has cancer is actually really, really, really small. So we screen 300,000 women per year, and that's around about an 80% population coverage of the eligible population. So that means that around 20% of the population, for whatever reason, do not attend for screening. 90% of people who come for screening will get a normal result. The chance of being told that you have low-grade disease is something around 5%. The chance of being told that you have higher grade disease, which would be a further step along the precancerous road, is around 1%. About 6,500 people receive a treatment in colposcopy each year for CIN, cervical intraepithelial neoplasia, which is this precancerous phase. And around 150 women will be diagnosed per year with cervical cancer in colposcopy. Another 100 to 150 will be diagnosed in our symptomatic services. So they haven't come with screening. They've come because they have symptoms and they've been diagnosed in a gynecology clinic. It's really important to remember that 40% of women who've been diagnosed with cervical cancer have never had a screening test, not once. So if we think back that our population coverage is 80%, so 20% of people have not had a screening test, but of the people who've been diagnosed with cancer, 40% of them have never had a screening test. So we've talked a good bit about screening. I'm going to talk briefly now about HPV vaccination, and I mentioned it in our timeline about how we've introduced it and that it's now available to all children in first year since 2019. And just recently, in December of last year, the government launched the Laura Brennan vaccination catch-up program in recognition of the wonderful work done by Laura Brennan in terms of advocacy around cervical cancer and HPV vaccination. So at the moment, anybody who hasn't had a HPV vaccine, and for women under the age of 25, they are eligible to attend and have a free vaccine done. Boys basically up to the age of 17 are also eligible, so it depends on what year they are in school or the equivalent if they're not currently in school, and any girls in secondary school who had not taken up the opportunity to have a vaccine are offered it at the moment. So that's a really important message to get out there. Anybody who hasn't had a vaccine and under the age of 25 for women there's a list of different places, vaccination clinics, where you can get them. And important to note as well, another recent change in terms of the vaccination is that NIAC, the National Immunization Advisory Committee, updated their advice recently, and through evidence and looking at lots of different situations around the world, it is now clear that 1 dose of HPV vaccine is sufficient for people aged up to the age of 25. In the past, people would have been offered 3 doses, 2 doses, depending on their situations, but 1 dose is giving the same immunological response response now. And this is great news. You know, young people don't necessarily like being injected with anything at all. And it just means that there is this opportunity then to broaden out our base of those who are eligible for the vaccine. It's still 3 doses for people who are immunocompromised, and there's a comprehensive list of what that means on the hpv.ie website, which goes through those people who might be potentially immunocompromised. And that brings us on to the idea of cervical cancer elimination and the World Health Organization's 3-pillar approach. So the World Health Organization in 2020 announced that it is now possible for countries around the world to work towards the idea of cervical cancer elimination. And what that means is that the rate of cervical cancer in a country would be less than 4 per 100,000 people. And that's not 0. 0 would be eradication. So sometimes people can be a little bit confused when we use the word elimination. It doesn't mean that there would be no cases of cervical cancer, but it does mean that it would be less than or fewer than 4 per 100,000. And if you remember, our rate in Ireland is 11 per 100,000 at the moment. So we have a little bit of a way to go. But the reason that cervical cancer elimination is now a possibility worldwide is because we have vaccination, as I mentioned, is going to be such an incredible primary preventive tool. And we also are able to offer effective screening and effective treatment. So what the WHO says is that if 90% of girls are fully vaccinated with HPV vaccine by the age of 15 years, and if 70% of women are screened with a high performance test, that means a HPV test, by the age of 35 and again by the age of 45, and if 90% of women who are identified with either precancer or cancer are given the appropriate treatment, if we have those 3 things true in a country, then that country is going to be on track to eliminate cervical cancer. So in Ireland, there has been a partnership developed between all of the interested parties and those who would be responsible for bringing these targets to fruition. And that has meant that we've been able to develop an action plan to bring us towards being able to set a date by which we can say that cervical cancer will be eliminated in Ireland. And I'm just laying out some of the steps that have been involved in the elimination project. So there was a media campaign launched earlier this year, which you may have heard a little bit about. There is a modeling project. So this is a data or maths-driven exercise, which is being done for us by the experts in Australia, because they are the experts on all things HPV, who are working out our rates of different things in terms of vaccination, in terms of screening, putting it all into some complicated maths program, and it's going to spit out a date for us. And then in November, we're hoping to be able to publish that date. So as I say, this will be the elimination date by which Ireland should be able to get rid of cervical cancer to a point where it's a rare disease. And the action plan is going to be based on that. So this is our little roadmap, which is kind of telling the whole story about how we have gotten to where we are in terms of cervical cancer elimination. Some of the other things that we're going to be doing throughout this year is looking at self-sampling, so people taking a sample themselves at home, a cervical sample, and testing for HPV rather than necessarily coming into a clinic, looking at developing our action plan, and as I say, hopefully that we will be announcing our target date for elimination in November of this year. So this is where we come to the bit where I'm, I suppose, very keen and interested to hear from your own viewpoint. These are some of the things that we felt that those of you in the pharmacist community probably do all the time in relation to screening. So encouraging patients to take up their screening appointment, talking to them about any myths or misconceptions they might have about it, talking to the public about cervical cancer. So our symptom awareness, again, remembering the symptoms of cervical cancer being irregular bleeding, unusual bleeding, bleeding after sex, which are things that people are often uncomfortable talking about, but certainly in the environment of with their trusted pharmacist, then they may feel more comfortable asking those kinds of questions. You know, obviously promotion of the HPV vaccination program is so important. And again, as we looked at that idea of getting 90% of our girls vaccinated, that really involves making sure that girls, parents, boys, everybody are on board with the idea of HPV vaccination, making sure that anybody who has symptoms is encouraged to make an appointment with their GP. Having leaflets and posters talking about risk reduction, talking about screening, talking about vaccination, just bringing cervical cancer into people's consciousness in a positive and proactive way. As I mentioned about smoking cessation is so important in terms of HPV persistence. And again, obviously all the supports that you provide to people who are in that contemplation phase of quitting smoking. And again, we all as healthcare professionals need to support each other, I suppose, in understanding the importance of cervical screening and the symptom recognition. Again, you know, pharmacists are such a huge source of support, ongoing support for people with any kind of cancer. You know, I would know from cancer patients how much they appreciate that support that they do get from their pharmacist. It's really important for all of us to stay up to date about information that changes all the time. It can be hard to keep track of different tests, different science, different vaccination schedules, all of those things. Obviously, by virtue of being here on a Wednesday evening, you're showing how keen you are in staying up to date with information. And again, you know, having advocates in the community is so vital for us who are, you know, potentially sitting behind desks and computers. Despite my former career as a full-time GP, I am now only in practice 1 day a week. So it's always lovely to hear from others who are working in the community about the real world, because we do accept that we don't always live in it. So these are just some thoughts that we had, but absolutely I was very keen to hear other opinions or thoughts about that. I know that Lynn is going to be putting into the chat there a couple of our links for various bits and pieces, but just a reminder, there's e-learning modules on HSE land and reducing cancer risk. On our CervicalCheck.ie website, we have a number of webinar recordings, we have our newsletters, we have guidance for the LGBT plus community, and then on screeningservice.ie, which is the National Screening Services website, lots of information there about elimination, about our own programme reports, equity strategy. There are also Translate Ireland videos, which explain cervical screening in a number of different languages, which can be useful for people for whom English is not their first language. And then there are screening posters and bits and pieces on healthpromotion.ie that might also be useful. So I'm tearing through things there, but hopefully I haven't gone too fast. And thank you all so much. That's my own email address there. I'm always really happy to have any bit of feedback, input, whatever at all that anybody wants to send to me. I'm more than happy to accept it. So I'm going to stop sharing there and I'll come back into the room.
Thank you, Sarah. That's fantastic. So we will take questions for Sarah at the end of the presentation, but I'm going to hand over now to AnneMarie DeFrein with the National Cancer Control Programme. So AnneMarie, in your own time.
Super, thanks, Mary Claire.
Thank you.
I hope everyone can see that there. So mine is very brief, really. I suppose I thought it was important to probably link in, you know, while we were talking about cancer and cervical cancer specifically, following on from Sarah's points, particularly about, you know, the role of pharmacists. I think we've all heard, you know, we're not going to treat our way out of this problem. And certainly one of the key focuses in the NCCP, particularly more in recent years, has been around, you know, early detection and prevention and about the public health aspects of cancer. And as Sarah flagged there, and I think Lynn has put the link into the chat box there are 11 short 10 to 15 minute C courses readily available on HC land, perfect for ticking those CPD boxes. But also, you know, it does help you when you're having those conversations with your customers, with your colleagues, with, you know, your over-the-counter staff and your technicians can all access them via the HSE land. So they can be certainly really useful for those kinds of conversations. We all know pharmacists are they're trusted individuals. And as Sarah again said, people are much more likely to talk to you about these things or about little things that are bothering them because, you know, everybody's so conscious, and particularly post-COVID, so aware of the, you know, that the GPs are so busy. And of course, you are so busy. And I think the public are increasingly aware of that, but they still will feel like they have a relationship with you and will be more likely to talk to you, So I think it's good to know. And certainly we've done those little e-learning modules, my colleagues in early detection and many of the girls in screening have done those. So they're nice, quick learns, little things as well. So following on from that, more specifically, I just wanted to flag a couple of resources more so around the treatment aspects for those very small numbers, and we're hoping to get increasingly smaller numbers, but for those people who do become patients with the diagnosis of cancer who do need to receive treatment. So I suppose, and many of you have, I did a webinar last year where we flagged this, but again, I just want to flag, that there's a number of us pharmacists working with the NCCP, and we have done national chemotherapy regimens which are readily available on the NCCP website, under our healthcare professionals page, and they're all there for you to access. These regimens would be a key enabler of safe and quality treatment of patients with SACT. And you'll increasingly see, instead of calling it chemotherapy, we tend to use SACT or systemic anti-cancer therapy, because as many of you know, chemotherapy has kind of grown and expanded, and now we treat cancer much more with hormone therapy, targeted therapy, and immunotherapies as well. So the SACT is becoming more of the catch-all term for the use of medicine and drugs to treat cancer. So the chemo regimens support a safe and evidence-based treatment approach. So they'll all be referenced, and they'll all follow a very standardized format. They're not intended to direct care, so the primary clinician, the consultant, be it the medical oncologist or hematologist in the hospital, will still determine the best treatment course for the patient, or of course radiation oncologist if there's a radiation aspect to it, but these are specifically about the drugs. And all regimens follow a standard template. So although they may be, some of them are 9 or 10 pages, the first page typically is, the detailed indication, the actual treatment drug, the doses, and the schedule, if it's once a day, every 3 weeks for 6 cycles or whatever that may be. There's an awful lot of these regimens now. We've got over 460 of them now on the website, and they do include the oral drugs as well, which would be the kind of things particularly you'll see more in the community, where you're dispensing a lot of the oral medicines. And we do have very robust development around these. We work with the consultants in the hospital and lots of other healthcare professionals working in cancer services, many hospital pharmacists and specialized nursing staff. They're readily available. So I really just wanted to let people know where they are, so that if you have something in particular, if you get a new patient on a new treatment you're not familiar with, these resources are there and can hopefully give you a lot of comfort in supporting your patient, And then just separately, we have developed a broader community pharmacy resource page, because again, recognizing the role of the pharmacist is much more and much broader and becoming broader all the time. We've just put a lot of useful resources into this. It might be, some specific things like the antiemetics that patients are on, whether they're on chemo in the hospital or in the home setting. There's a couple of guidance documents, and we also reference a couple of international good sites, like coming from Canada and the UK and Australia. So there's quite a detailed resource page there, and it was really just to share with you again that if you have a particular interest, or if you have a particular patient with, who's asked you a question and you're looking for somewhere with good information, that's there, and we have plenty of guidance documents on that page as well. There's a section as well, the use of alternative medicines, for example. So it's just to give you a flavor of the types of things on the site. And we hope you find it useful. There's also, we have an email on the page. So as always, if there's anything you would like to see more of, or any feedback you have, we'd welcome that also. Thanks, Marie-Claire.
That's great, AnneMarie. Thank you very much. So we will open the floor then to questions. If you have any questions, if you want to type them into the chat box, I'm sure our speakers will be happy to take questions. I might start off, and this is just my own, I suppose something I've didn't occur to me. Why, and it's for Sarah, what is the rationale for the cutoff of the HPV vaccine at 24 going on 25? Is there some particular significance of that age in relation to HPV?
So I suppose the HPV vaccine is going to work best if people get it before they become sexually active. We know that for definite, and that is the rationale for it starting so young. We'll say so starting maybe at 12 or 13. At the same time, we know that there is advantage for when you think about how many different HPV types there are out there. So I mentioned that there's over 100 different types of HPV virus, and the vaccine will protect against 9 of them. So the Gardasil 9 will have 9 different HPV types in it. You may not have been exposed to one of the high-risk types in your first or second sexual encounter. However, the more sexual encounters you have in your life, it's a little bit more likely that you might be exposed to some of those high-risk types. I suppose the decision around the age is probably a little bit more to do with a lot of other decisions that we make from a public health perspective, which are taking the greater good into consideration. So where is the place that you're going to get the most benefit for the resources that you have? So we get a lot of questions about people saying, well, I'd like to get the HPV vaccine and I'm 30 or I'm 40 or whatever. And so these are the conversations that we would have then from a GP perspective with an individual person. We will say, well, it's very likely that you've already been exposed to HPV virus. We can't say for definite which one you have been exposed to. It might be that you have not yet been exposed to a high risk one. And so therefore you might choose that you might like to get the vaccine, which includes the most common high risk ones. But we cannot say for definite that this vaccine is going to be of huge benefit to you, but it likely might be, and that diminishes as time goes on. There isn't any risk to getting the vaccine. It's just that its effectiveness is going to be less. But what we are saying to people who are falling outside of the NIAC recommendations is that then that's that is a choice between the doctor and the patient, and unfortunately, obviously, somebody would have to pay for it. So then you're adding in what used to be €600 into the conversation for people as well. And those are considerations for people to take. And it can be really important as well to have the conversation around getting the vaccine doesn't mean that you don't need to come for your screening test, which some people can sometimes believe as well. So they think, well, if I just get the vaccine, then I'll never have to have this awful smear test that people talk about. And this is before they've even encountered the idea of a screening test. And so obviously it's really important to make sure people know that when you have the vaccine, you also need to continue to have your screening tests.
Thank you for that. That's very interesting. It's useful information for us to have as people might be coming in with that kind of question. So it's useful to know that we can refer to GP, and it is a possible conversation that can be had as opposed to a hard no. Thank you. Another question I have in relation to obviously this women of this age might be having children, and in terms of them getting back into the system around cervical screening, how does that work if people come in and ask us about that kind of thing? Does it automatically happen at some point after birth, or how does it work?
Yeah, so traditionally cervical screening and pregnancy got all kind of jumbled up, unfortunately, and it was as if they were related to each other in some way. And that came about when people were told or suggested to have a smear test at 3 months after they had their baby. This used to be the kind of advice that came out there, and everybody would arrive in 3 months after their baby was born saying, oh, I must have my smear test, I've been told. But actually your screening pathway, your time between your screening tests stays exactly the same, whether you have a baby, whether you don't have a baby. It's nothing to do with being pregnant or not. The only time that it makes a difference is that for most people, they would choose to probably not have their screening test right in the middle of their pregnancy, which is totally fine. And for most people, they wouldn't need to have a screening test. So if your screening test is due and you're 6 months pregnant, you just leave it until after you've had your baby. There's no major difficulty about waiting, but that's because it's due. Then you have it after your baby is born. If you had your screening test 1 year before you were pregnant and you're not due again for 5 years, then you don't need to do anything. Just because you've had a baby doesn't make any difference. You wait until your 5 years is up and you come back again then. The only slight difference would be if people have been found to be high risk. So if they were found to be HPV positive and they were due to have another repeat test, or if they had abnormal cells tested in their last screening test and then they fall pregnant and their next test is due or their appointment at colposcopy is due, they should still attend that appointment. So if you've been told that you do have a reason to go to colposcopy, you should go, even when you're pregnant. The colposcopist will talk to you about whatever they need to do. Sometimes it's just simply them looking at the cervix. So there might not need to be any like test or intervention done. But for those people, it is really important that they would attend while they're pregnant. But for everybody else, if your last HPV test was normal and your next one isn't due, just because you've been pregnant doesn't mean you need another screening test. And if you are pregnant at the time that your test is due, you can delay it, no problem at all, for 6 months, 9 months. That's not going to make a huge difference for you, as long as you're not having any symptoms. All of the things that we would usually say, if you have any other concerns, obviously you talk to your GP about that. But in the usual run-of-the-mill screening, and the reason to wait after pregnancy is just that the hormone changes at the neck of the womb can sometimes make the taking of how the cells look under the microscope a little bit different, and that's why we wait 3 months after pregnancy.
Right. Thank you for that. So I think the suggestions you came up with, particularly for community pharmacists, as you say, we're in terms of health promotion around this subject. Many of us are doing that, many of those things already, but it's really helpful to come together as a package so we can be reminded of the various things that we can do in our pharmacies, and as well access to resources around health promotion. So thank you for highlighting those. And if anybody has anything that they're doing in their pharmacy that they find particularly effective, please do share into the chat. We'd be delighted to know, because obviously uptake around vaccination is very important, and obviously encouraging people to partake in screening programs as well as another part of our remit. That's really important. So we don't seem to be getting any other questions at the moment. So what I might do then, we might share the feedback survey if that's okay. So that'll be coming into the chat soon. Sorry, Sarah. Yeah. Yeah.
No, I could just see a question.
Oh, sorry, it's not
the chat there
for me. Okay, thank you. Sorry, I didn't see it.
Saying, is it possible to test negative for HPV, so a previous infection that is now cleared by itself, but for cancerous, precancerous cells to be present that may be missed in screening, or do they go hand in hand? So that is an excellent question that comes up a lot. So people would be saying, well, I've tested negative for HPV, but my cells haven't been checked. And so how do you know that there isn't cancerous changes there? So I think I'm understanding the question correctly. So what we know is that it is the presence of persistent HPV that makes cells change to cancer, for want of a better way of putting it. So the cells can sometimes look a bit different, and they can have abnormalities in them. But if there is no HPV present at that time, then those cells are not going to become invasive cancer. So you can have unusual looking cells or potentially abnormal cells in the absence of HPV, but they are ones that are going to go right back to normal by themselves. So it's the HPV being present that is the risk factor for cancerous cells. So you've tested negative for HPV, you may have had previous infection, but that has cleared. So we know today, on the day you had your HPV test, that you don't have HPV, you don't have persistent HPV. And then we know that it's not there to cause the cancer changes in those cancer cells. And that can be sometimes useful to speak with people who would have had in the previous screening program, when it was only their cells being looked at, and they would say, oh, but my cells were always abnormal. Every time they were looked at, they were always abnormal. And I should maybe have them checked now all the time or regularly. But actually, if we had known before, when we were looking at those abnormal cells, if we had known in the past that there was no HPV there, we wouldn't have needed to have had that extra surveillance. We would have been able to be sure that without the presence of HPV, those cells are going to go back to normal by themselves. So I hope that that would be a reassurance for anybody who's had that experience.
Thanks, Sarah. There are a few more questions popped in. So the 9 strains in Gardasil, are these just the cancer causing HPV, or how are they chosen?
Yeah, so originally Gardasil was 4, so it had 4 different strains in it initially, and those were the 2 main ones that cause cancer. So that's HPV 16 and 18 are the main high-risk ones. They cause around 70% of cervical cancer are caused by just those 2 strains, 16 and 18. And then in the original Gardasil, they also added 6 and 11, which cause genital warts, because if you're going to be giving somebody a vaccine, it's nice that they might know that that'll prevent them from getting genital warts as well. In the Gardasil 9, they've included more of the high-risk ones. So they've still maintained those 2 that cause genital warts. which don't cause cancer at all, the subtypes that cause genital warts, but they have included the next ones down in terms of likelihood to cause cancer. So they've kind of rated them according to their risk. And as I say, 16 and 18 are by far the most likely, but the ones then that are next most likely have been included in Gardasil 9. I couldn't tell you whether they have any intention of adding more, because I think that probably covers the 98% of the high risk ones are within the Gardasil 9.
Thank you. Is there a way for people to check if they've had the HPV vaccine and they can't recall if they've had it?
That is an excellent question that I don't know the answer to. And I don't, I know that if you're, there's so much information available through hpv.ie, the website, but there isn't a central register. And I don't know, Lynn, if you have any idea about that, but that isn't something I know the answer to. Sorry about that.
No,
Lynn, you don't know?
I don't know. There's no central way people can check. If it's through the schools program, they'd probably have to go back through that system. Yeah.
Okay,
there's no central. Yeah.
Is there a high risk category for people who have a family history of cervical cancer that allows for more frequent screening? What would be the cost if somebody wanted extra screening within the 5 years?
So there's very little evidence to suggest that cervical cancer is a hereditary cancer in the sense that some others are. What we know is that cervical cancer can affect certain communities more than others, but that is more to do with, I suppose, what we might call the social determinants of health or the environmental aspects of a person's life, rather than being a hereditary cancer as such. So while there certainly can be families that have cervical cancer, going through generations, it's not a hereditary cancer in that sense. Again, remembering if somebody has a high risk category, there aren't that many cancers that we can really pinpoint such a risk factor in the way that we can with HPV related cervical cancer. And the finding out whether you yourself have HPV or not on any given day is the most useful thing that you can do in terms of your I suppose, risk assessment. And that's not really related to your own family history. Having extra screening, so that would mean having more HPV tests. There isn't an advantage to that, because if I have HPV today, I will be tested again in a year's time to see if I've cleared it or not. If I don't have HPV today, even if I pick it up tomorrow, HPV is going to take 15 or 20 years to cause cancerous changes in my cells. So by the time my next test is due in 5 years' time, I'll have had HPV for 4 years and 364 days. It still won't have put me in a risky type situation. There isn't a massive benefit for repeating a test over and over. The intervals between the tests are based on the length of time that it takes for the HPV to cause problems.
Thank you. Do the new NIAC guidelines apply to women over the age of 25? Should they still just receive 1 dose of Gardasil 9?
So the NIAC guidelines will only refer to women under the age of 25 because that's who they're dealing with. But the science would say that over the age of 25, the immunological response is not as well defined. So this advice is based on the research that has been done about the, I suppose, the immune systems of younger people. We know that your immune system, as you get a little bit older, it might not respond in the same way. So that's why this advice refers to people under the age of 25.
Thank you. Are there supplements to help clear HPV more quickly?
There are supplements available that suggest that they might clear the HPV more quickly. The research that has been done on those does not meet the evidence thresholds that we in the screening program would need in order for us to be able to recommend it. So there are some commercially available products which have not been tested to a level that we would be able to say is a strong evidence base.
Thank you. And can all strains of HPV, including those that cause genital warts, be cleared from the body by the immune system?
Yes, they can. So again, if you've had HPV and it's being cleared, we don't necessarily know that when we do a test. But what we do know is that HPV is the type of virus that a body can get rid of. And we know, for people who've had HPV in the past, they test for, so in other countries, they might test for different genotypes, different subtypes. And we know that you can get one type, clear it, get another type and clear that.
Okay. Thank you for that. We've got a flurry of questions in there. So thank you very much, everyone, for asking those questions. And thank you for Sarah for answering them. So what we might do then is share our feedback survey and make you aware of the next date for our webinar as well. So as always, would encourage you to complete a reflective learning cycle based on your attendance this evening, and thank you very much for coming along, or if you're listening back to the recording. So our next webinar will take place on Wednesday, the 22nd of March, so a few weeks away, and we will advertise that through our usual social media, and keep an eye on your inbox as well for your email, and you'll be able to sign up for that webinar. So hopefully we'll be able to advertise that in the next week or so. So thank you very much for coming along this evening. Thank you to Sarah and to AnneMarie and to Lynn as well for supporting there in the background. That was a really excellent webinar. As I mentioned at the start, those resources that Lynn was posting into the chat box, we will collate and share them alongside the recording of the presentation as well in the coming days. So thank you very much, everyone. And we will see you in a few weeks' time, hopefully.